Hello, dear colleagues. I would like to thank Dr. Iakovou and the organizing committee for the invitation to participate at this great Congress. So I'm very happy that also Dr. Georgopoulos saw this very interesting case, because the following case is similar but not in a native valve. Back then it was the first basilica in Greece, but that is the meaning of our congresses. We exchange our experiences and we enrich the therapies that we can give to our patients. So our patient, TAVR valve in valve with a critical coronary occlusion risk, 81 years old with a BMI of 23, a short of breath and fatigue in the past 5 months with a NIA score of 4. For the patient history, surgical AVR Magna 19 back in 2016. The transthoracic echocardiography AV Vmax 3.6 meters per second with a mean gradient of 28 millimeters of mercury, AVA 0.7 with a LVEF of 65%. We assessed the valve also with a stress echocardiography with a Vmax elevation of 4.7 meters per second and a mean gradient of 43 millimeters of mercury and AVA of 0.8 square centimeters. We have to emphasize that the patient has also a very impaired mobility with right and left shoulder arthroplasty and right hip trochanteritis. So we see the X-ray of the patient with the, among others, the position of the surgical valve and the transthoracic echocardiography with the LV hypertrophy and the bioprosthetic valve with deterioration at AV max of 3.4 meters per second, and after the stress echocardiography, 4.7 meters per second. The Magna number 19 valve is a fracturable valve with a true balloon size of 20 millimeters and a true ID of the valve 17 millimeters. The CTA showed no problems concerning the transfemoral access of the valve. And here we see the axial analysis where we can assess the proximity of the surgical valve, especially to the LCA. We can see here the pre-procedural CT assessment with a VTC to LCA of 1.6 and a VTC to the RCA of 2.4. And here is also our assessment concerning the proximity to the coronary ostia. And here we can imagine if we place a valve in the surgical valve, if we would place a valve, then it would definitely occlude the ostium of the LCA. Here we can see moving upwards the proximity to the LCA, and the last picture, as we see at the STJ level, it would so a valve would definitely occlude the LCA. Here we see a virtual circle, a virtual valve of 20 millimeters, and the how it would affect the LCA. And we see moving upwards here, as we said, at the STJ level, it would definitely occlude the LCA. So from the known up, we see that the ideal valve would be an S3, 20 millimeters, and we would align the S3 inflow 15 to 20% below the fluoroscopic marker in the Swin ring. The coronary angiography showed no relevant stenosis. There's the right coronary artery and the left coronary artery And here we would also assess the proximity, as we said, of the LC ostium to the surgical valve. So in our heart team approach, we have the aforesaid patient with a very high Euro score and STS score, and we decided to proceed with the valve-in-valve with basilica and bicoronary protection. Here we see 7 French AL2 guide catheter, and as Dr. Georgopoulos also mentioned, we have to proceed with 2 orthogonal views to assess the deepest point of the cusp, and we have to, of course, to be in the middle. We used the 0.021 inches J wire in the LV and the flexor guide of 8 French. Through the flexor guide 8 French, we used an Amplatz gooseneck snare. We have to emphasize that the lasso of the snare, it has to be near the plane of the valve, so that we won't go too deep and maybe also affect the mitral valve. The next film, we see the L2 guide with 7 French with the Astato XS guide wire within a fine cross. And here we see, after we have checked with orthogonal views, the penetrating of the Astato wire through the cusp of the valve, aiming towards the snare, the gooseneck snare. Here we see the snaring of the wire, and afterwards we have to externalize the wire. It needs combined teamwork. One operator has to push, and simultaneously the second operator has to pull the wire, so it can be externalized. Here we see our team and Dr. Spargas denuding the Astato wire before inserting it. We have to measure exactly the distance where we will denude the wire and then shape a V shape, so we can proceed with our basilica. Here we see the simultaneous pulling of our guides. The pulling has to be firm and constant. And then, of course, we assessed the outcome also with an ultrasound. As we were sure that the basilica was successful, the treatment, we proceeded with an implantation of a 20 millimeters S3 Resilia valve, having also wire protection in both coronaries. And immediately after the implantation, we assessed our situation and saw very good flow through the coronaries. This is the post-dilatation with an Atlas Gold balloon, so as to facilitate the optimal expansion of the valve, which also refers to our discussion concerning the halt, ham, and thrombus on the valves. So it is also a very important aspect to have a correctly expanded valve. Here's our artography showing a good outcome, multiple angiographies to be sure about a good flow in the LC, and at the end, a good hemodynamics. echocardiographic assessment. We were also satisfied. No PVL or transvalvular insufficiency, and a good AVV max after the implantation. And the 1 month follow-up, and we also have, meanwhile, the 6 month follow-up of the patient. She's doing fine, and we also had a stress echocardiography with the LAD, CFR, showed also a very good outcome. Thank you for your attention.
Thank you, Kyriakos. It's a very complicated but very nicely done case. I want to ask you if you ever had any complications from the Basilica technique in your hospital.
Thank you, Dr. Manginas, for the questions. We had actually didn't have any complication until now, thank God. I have to say that these procedures have to be very thoroughly and carefully planned in terms of anatomy, in terms of even measuring the wires. We also considered carefully other techniques like chimney, for example, but we, in this case, we saw that there was a very narrow space, and implanting also stents, and this very narrow space maybe would not facilitate and assure enough flow in the coronaries. So until now, very careful planning, and thank God we didn't have any major complications.
Did you use a transophageal during the procedure?
In this case, we had a very good transthoracic views, and this is how we assessed echocardiographic our patient.
This is a great question, really an excellent question, actually, because I think I'm a fan of DOE during Basilica, because if you, although you are sure that you're in the right position, during the punction, if you don't have enough backup, maybe instead of 8 French, 7 French AL2, was it 8 or 7?
The 7 French.
7,
yeah.
Okay. If you have a 7th French, which is, you don't have the backup that you would have with an 8 French, and you have a bad calcification, maybe, although you are at the right position, while trying to push and lacerate the leaflet, the catheter cannot offer you the backup and can slide sidewards and then lacerate another position. So I think TOE during Basilica, for me, is a luxus, but it is also mandatory because you're certain you stayed in position.
Thank you. And meanwhile, we also use the TOE guidance. Yeah.
Yes.
Also, did you fracture the valve afterwards?
It was not our intention to fracture the valve. We just wanted a good post-dilatation with an Atlas balloon.
Perfect. Excellent case. Really, really well done. Okay,
Thank you.
So now we have